You know, I had a fascinating interaction about 2 days ago that really embodies and personifies the decrepit state of the addiction industry. And one of the things you got to really always keep in mind, and I will remind you of this multiple times, I'm going to use certain terms and they will always mean certain things. When I say industry, I mean the business of addiction. That is separated in my mind from academic medical practice of addiction, and to some extent county facilities and indigenous people where you're serving them medical care. So we are only talking about the industry of addiction, unless if I say it so otherwise. In any case, I had this amazing interaction about 2 days ago that really embodies how decrepit this whole system is. I went to see a lady, and this was a non-profit organization, and she was a very nice lady. And this gal was basically a referral service, and supposedly they did some sort of vocational training and so on and helped their clients get insurance. And I sat down to talk to this lady, and what she was doing was interviewing us to see if we're interested to use her services, which for all intent and purposes was, you know, you donate a certain amount of money and they will refer patients to facilities that meet their standards. This lady sat down and asked us some questions, and I asked her, what about you? And the first thing she said was, well, I come from the health industry, and when you say that to me, I already know you're not a physician or a clinician, right? When you say I come from the health industry, that could mean anything. That could mean you were the insurance guy or the lobbyist for Novartis, a big pharmaceutical company that's ripping off the planet, and this guy's going to the White House and making sure every law is passed so they can do every kind of testing in the way they want so they can sell their products. So that's what I think of when you tell me I come from the healthcare industry. Now, she goes on to talk, and again, her role is referral to detoxification centers, intensive outpatient treatment centers, partial hospitalization, outpatient, whatever. And during this interview, I guess, she talks about it, I was asking her, well, what is your engagement with the client while the client is at detox or a residential treatment center or partial hospitalization? And she said, we follow them and we take care of their case management issues like prison, vocational work. And I was like, great. And in that discussion, she very clearly went out of her way to point out that we do not interfere with the medical aspect of the care, and we do not interfere with the psychosocial behavior aspect of the care. Fantastic. I'm like, cool. 2 sentences later, this gal turns to me, who I'm a physician, board certified physician, practicing medicine for years, teaching medicine for years, professor of medicine, and she asks me, what do you think about Suboxone? And I get this from every person in this industry. And I found it so offensive, but now I'm learning how to negotiate the terrain of this industry. What I felt like saying is, really none of your fucking business. What would you know? I mean, do you go to your doctor's office and say, what do you think of a beta agonist for my inhaler? Because this is my opinion. Do you do that? Do you go to your cardiac surgeon and say, well, this number of vessels are clogged. I have an opinion of what should be done to me. What's your opinion? In the sense that you're quizzing him. She was quizzing me. And in a sense, she was saying, if my views align with her views, so she can go on and refer to me. So my immediate response was, I was trying not to be polite. Again, I'm learning to be more politically correct and interact with these people in this world of industry of addiction medicine. And I said to her, well, I don't know what you're asking. What I felt like saying is, are you a medical doctor? But I said, I'm not sure what you're asking. And I said, did you want to learn something about Suboxone? And, she had a little step back. She said, oh, I'm just wondering what your position on it is. I'm like, well, my position, I'm a physician. And since we have all decided to agree that this is a disease model. Everyone says, yeah, it's a disease model. It's a disease model. Okay, it's a disease model. Therefore, let's approach it like the disease in every way, shape, and form that a clinician approaches a disease. You know, he looks at outcomes, risk, benefits, long-term clinical sequelae. And I told her, well, I'm pro Suboxone because it's first-line treatments by all consensus groups across the globe. In addition, there's robust data that this should be the first-line treatment. I'm not going to go into the statistics. If you guys want to know about the statistics in the papers, I can put those up at a later date, but it is. So, you know, when you come in to the emergency department and you have an asthma exacerbation, first-line treatment is a beta agonist. Why? Because it works. So that's what I told her. Then she sat back, sort of, she was doing this thing, and then she gave me her opinion, started to give me an opinion, stopped for a second, and then she's like, what dose do you use? So again, I explained to her, I'm not sure what you mean. I was kind of being facetious, but, and the reason I was doing that is because the answer is this. There is no particular dose on the person. There's an induction, this thing called an induction, there's a titration, and then there's a maintenance, and then there's a ceiling effect of a particular dose that you are aware of, and for different patients, they will fall somewhere in between them, and there is a bell curve that most patients will fall in the middle of that. So how do you answer that to someone who has no idea what you're talking about? I didn't know what to say. I said 8, 12, 16. She's like, oh God, 12 is such a huge dose. And I just kind of wanted to say, have you given it? Do you know what this is? And a little bit later in the conversation, we were talking about something else which I can't recall. And my response was, I never give buprenorphine in that case. And so something happened. I said, I never give buprenorphine in that particular scenario. Now here's the caveat of this. Buprenorphine is Suboxone for all practical purpose. And she turned around and said, oh yes, I would never use something like buprenorphine. And I realized she didn't even know buprenorphine is the generic name for Suboxone. But this person is dictating, at least in the locale where I live, the treatment of patients with the disease of addiction. She is dictating it in multiple ways. She is advising patients what they should do. She has no business doing that. In fact, that would be illegal, right? You're giving medical advice without having a medical degree. 2, she's actually probably in some ways forcing physicians to behave a certain way just so they can get money. Now, I don't know what kind of physicians do that, but it seems to be quite prevalent in the milieu of the environment that I've been interacting with. She has no business to have any thought. And I'm not being mean or cruel because I don't pretend to have any thought with the engineer. I don't have to pretend that I have any thought with Owen, who's filming this whole set right now. I could, he just explained something to me about the camera and the film and the editing. I had no idea what he's talking about. It'd be silly if I gave him a thought. Yet this lady, amongst all of them that do the same thing, is giving me her thought and really trying to tell me this is what I like, so this is what you should do, regarding a very, very serious disease that is not getting better, destroying lives, destroying families, utilizing hundreds of millions of dollars worth of resources, and killing our children. That's the addiction industry. And that event, that person, and she was a very nice person and maybe trying to do her best, personifies what is going on in this industry. Just feel.
That's awesome. That's perfect.
We're gonna get fucking sick.